So we have a live case from CMC Vellore.
Hello.
Hi, Dr. George Joseph. This is Dr. Samir Dani, and we have an illustrious panel.
Hello.
Hello.
Hi, Samir.
Hi, George. Can you hear us well?
Yeah, I can hear you well. Can you hear me?
Yes, very well.
Okay. So we have a patient. We've been waiting for the last 20 minutes with everything open. So can we just see the slides quickly? Are you able to see the slides?
Yeah.
Okay, so this is basically a 70-year-old gentleman who is a chronic smoker, and he presented with 4 months of abdominal pain, and there is an obvious aneurysm there. And next slide, please. So the CT was done, and it showed a huge aneurysm, which is 8 centimeters in its maximum transverse diameter, and it's partially thrombosed. And the next slide. Yeah, this is the 3D reconstruction from the posterior aspect. I chose that because the superior mesenteric doesn't come in the way. So you can see that there's a very complex neck. And after that, the iliacs are ectatic and very short and take off almost at right angles from the aorta. And next slide, please. Yeah, this is a close-up of the neck from almost anterior view. The right renal is a little lower than the left, so we'll have to start our device from the right renal. And next slide, please. Yeah, and this is the lateral view, and you can see that there is a lot of angulation in the neck. It's a conical neck which is kind of flaring out as it goes down. And there are 2 right angle bends there. So we'll have to be looking at this neck from a cranial angulation to open it out while deploying the device, and which is what we're going to do. The next slide, please. So this is our plan. So the neck was 21 millimeters on top and 26 before the aneurysm starts. So we have chosen Endurance 28 millimeter device, which we chose that because of its ability to conform to these very difficult anatomies. And we're going in from the left groin, although the course is a little more tortuous, but it would make the contragate cannulation a little easier. And then both the common iliacs are short and ectatic, about 16 to 18 millimeters. So we hope to extend bilaterally into the common iliacs with extensions that are 16 on top and 20 at the bottom. So we hope to seal in the common iliacs and spare the internal iliac arteries bilaterally. I think that's the last slide. So what we have done now is we've done a baseline angiogram. So hopefully we'll seal at both these places. So we want to be sure that we start our device as high as possible. So the next angiogram. So what I've done is I've got a catheter from the other groin positioned at the ostium of the right renal artery, and I've stabilized it with a wire. And when I test from here, I'll know exactly where the right renal is. And then from the left groin, I've taken in the Endurance device, and it is now in place, ready for deployment. You can see that the radiopaque markers at the top of the device is where the covered portion starts. And then there are 2 other markers. One is at the flow splitter, and the other is at the contragate. Now the contragate is oriented to the right side in this patient. So I'll now proceed with the deployment, as I think we are a little short on time. And before I start, I'll just introduce my colleagues here. This is Dr. Sujit Chako. He's a cardiologist. Sohail is our registrar. Then we have our vascular surgeons, Edwin, Stephen, and Indrani. And we have our anesthetist, Dr. Kirbakaran. All right. So we'll go ahead with the deployment. I'll start deploying a little higher than the renal because I have the option of pulling down at a later stage. So I'll open the first two stents. Okay, so I've opened a bit of the device. Now, Sujit, can you just give me a test there? Yeah, so Sujit is testing. Now, I'm in a cranial 45-degree view, AP cranial 45. I've lost contact. Yeah, I think this is fine. No? Okay, so now I can release the, I think they're not hearing me. It's okay, no? Don't want to come down too much. Yeah, I think it's okay. But we lost. I don't think they can hear us and I can't hear them.
We are able to hear you.
You're audible, sir.
But only thing is slightly there is a disturbance in the transmission.
Okay,
I wanted to know that you cannulated
okay, I think we'll just go ahead. I can't sit here like this. They can watch us later.
Yeah, you cannulated the renal artery to know the level of the renal artery.
So
Isn't that comfortable from the radial?
Now. Okay, we'll just do one good angio just to be sure that the renal is not going to get covered. Yeah. Okay, I think I'm back with them. I can hear some feedback. Yeah. So I'm now in the process of deploying the device. I just confirmed that I'm at the lower border of the right renal.
Looks okay.
So I'm releasing the device till the contra gate springs open. Yeah, so now you saw that the contra gate opened and the next thing is to open the top cap. So what is required is there's a, can you show this? Yeah. There's a wheel here which we spin around and that, can you give an insert of that fluoro plus this?
Can you make the fluoro bigger and the hands
Okay, so there the device is opened. Yeah, the bigger on the fluoro. Okay, we have opened the device. Now one more angio just to be sure that the renal is flowing. Yeah. Okay, so the renal is spared. And so now I'm going to complete the release. Show lower down, please. So this stage I can do a quick release. Okay, so I've released the device and it's essentially opened within the sac of the aneurysm. Okay, go back to the top, please. Okay, so the next thing is to rotate the whole device and take it up, free it of this, yeah. And then, yeah, now I rotate the spring wheel back. Okay, so now that the top cap has come and affixed itself to that knob that is there. Show lower down, please. So now I'm going to bring the whole device down with a little bit of rotation. Yeah, now it's inside the device. So now we oppose the sheath with the nose cone. So I'll now hold the blue sheath, blue handle and pull the gray. Follow it, please. Okay, so now we've got the device open. The 14 French sheath, please. So the next thing we are going to do is we're going to extend the ipsilateral limb into the common iliac artery and land exactly where the common iliac bifurcates. Now the challenge in this case is that the common iliac is very short and we want to use the whole length of it. It's also ectatic, so this device is going to be a 16 on top and 20 at the bottom. Okay, light here, please. Okay, so we'll pull this device out. Okay, that's right. Now bring that sheet, please. So this is a 14 French sheath. It is a little smaller than the device that went in. That was 18 French, but it may be enough to give us some hemostasis. Take the dilator out, please. Yeah. Bring the marker pigtail now. So next we'll bring a marker pigtail and place it there to know what length of extension we need. All right, so here we go. This is the marker pigtail coming in. Just rotate it a bit. Don't move. Just hold the wire. Oh, shit. Edwin. We need a little bit of help with hemostasis here. Okay, that's enough. Okay, now let's take a test shot through this. Just inject. Fill the sheath with contrast. Show a little lower down. Yeah, no, just some, can you just put on a glove and just help me with this? Okay, we're ready for the angio, we're ready to go? Okay, what we can see is that the main device has come into perhaps the beginning of the common iliac, and then we have about 3 centimeters horizontally. So the pigtail is not really aligned coaxial with this. Okay. So we'll change the view to AP view. Let's see if that, maybe we should. Okay. One more picture now. Yeah. Okay. That's a little better. We can see the iliac bifurcation now quite well. So we need to end there. So below the device we have to extend by 1, 2, 3, maybe 4 centimeters. So, okay, the 90 device would be better. Okay. All right. So we'll take a 16, 20, 90 millimeter device. Okay, take that out. Now the challenge is going to be to end at that spot because it's not, there's a lot of tortuosity which will eat up some length of the, yeah. So maybe what I can do is to pull this renal catheter out and make it look down this side so that we can that way be able to see this side. Okay. Test that. Okay. Maybe we need to go down properly. So we'll take the Teramo wire and pass it down. Wet it, please. Okay, so I'm bringing a Teramo catheter from the other side. It's a very tortuous anatomy, so we are bouncing off one ledge-like thing there. I think perhaps we are into the internal iliac, which should be all right actually. Okay. All right, so this is possibly just nosing into the internal iliac. Okay, just take a test shot, please. All right, so we can see the internal iliac origin. It's going to be quite difficult to be very precise about this, but we're just hoping that we can get away landing in the common iliac and sparing the internal iliac. Now, if it comes to the worst, we have to extend the device into the external iliac. But okay, so we've got the device ready now. We'll take this sheath out and eye up. So I'm going to take this out. It'll bleed a bit. Okay. When there's so much tortuosity, it's very difficult to figure out how the graft will lie finally. And it's a little bit of luck and guesswork to land exactly where you want to be. All right, so yeah, show higher up, please. This is we don't have to go to the bifurcation. This is the ipsilateral. So we can be lower if we want to. Yeah, it shouldn't go above the bifurcation. Yeah. Okay, so now the issue is this wire is taking the absolute straight path through all this tortuosity, and when we deploy the device, it is going to eat up some length, and we may end up a little higher than where we want to be. So I may actually start a little lower. Just show lower down, please. Yeah, just a small test. Yeah. Okay, so I'm going to start the release, and what I'll do is, as I deploy, I'll feed in the device from below. So here we have started the deployment. No, my glove got trapped in this. I wasn't looking at that point of time. Okay, so we've released it. So now we'll actually take it out and then we'll see what. Show the top, please. Okay. Hold the wire. Show lower down. Okay. Now we'll take it out. Can you get that 14 French sheath ready? Now we could also test from here, and I don't know if that will help in any way. Yeah, well, you can see that the internal iliac is flowing, but then, so we have not come into the external. But whether we've got a seal there, we don't know. Yeah. Okay, is that sheath ready? Okay. Okay, take it out. All right, get the 14 French sheath, please. Okay, dilate it out. Right, so now I'm going to do an angio from below and see what sort of sealing or seating we've got with the device. Yeah, I think it's reasonable. It has come into the common iliac, and it has spared the internal iliac. It's in fact a little off that. So maybe what we need to do is to balloon that so that it smoothens out. Can you get us the Reliant balloon, please? What I'll do is we'll fix this first. We need to then, get through the contralateral gate and put in another limb on the right side. But I thought I'll just balloon the top of the device so that it anchors well onto the aorta. And then the bottom also, so that it molds itself well to the iliacs. We need a syringe, not this, a 50 cc syringe. With very dilute contrast. Now there is some friction here, so I don't want to push hard. Maybe we'll take the dilator, take the balloon out. We'll take the dilator of this 14 French sheath. And then we'll take the sheath up and then bring the balloon in through the sheath so that we don't snag the device. So the dilator has gone through. Now I'll try to slide the sheath through. And I'll just try some rotation to, the wire is coming back. Can you show the wire, please? Follow the wire up. Okay, now back here. Yeah, okay, so now I'm just taking the sheath in. Follow it up, please. Okay, now the dilator out and the balloon in. You can see that the top of the device has sort of molded itself to that small bulge or mini aneurysm there in the neck. Hopefully it has sealed at the top and the bottom of that. Okay, now we'll just, no, don't need to. Okay, so we've ballooned the top. Now we'll move it down. Follow it down, please. Overlap zone also to be inflated, I'm told. So we'll just gently we're inflating the overlap zone now, and then we'll come down to the to the bottom of the device. Yeah. We're almost at the bottom, but what's happening is part of the balloon is still in the sac of the aneurysm. Okay. Okay, so we are done here now. So we're going to now work on the other side and try to get through that contra gate. Get the thermo wire, please. So I'm starting off with just an ordinary Judkins Wright catheter, which usually works in most cases to get this contra gate cannulated, but sometimes we need different shapes, and if it comes to the worst, sometimes we have to come from the arm and snare it out from below. So we'll try a little bit from here and see what we can achieve. Talking device. I don't know if this, everybody is familiar with this talking device, the Alcott talking device, which is good for talking 035 wires. Okay, give me another view. We'll have to try a little RAO. No, go a little LAO then. Yeah, you can leave it, I think. Go a little LAO. Yeah, okay. So this may be through, but we'll have to confirm it. Just stay there. I'll just test through this. Some people put a pigtail and rotate it within the device to be sure that. Okay. You can see that this device also rotates within the. Okay, you ready to inject? Okay, looks like it's in the device. All right, let's put back the wire, please.
Can you zoom it?
The wire again. I think we have about 10 minutes more, so in that time I think I'll just I just have to extend put in the contralateral limb and balloon that, and hopefully with that we should be done. Okay, AP view. Okay, give me another of those stiff wires. Now there is Medtronic has their own wire now for all these sort of procedures. Mahesh, what's it called? Archer. You want to show the cover of that? Yeah, this is the. Actually, till now we were using the backup mirror from Boston Scientific. And can you show that? And also the Lunderquist from Cook. Okay, take that out. And bring the pigtail again. So we need to measure this side also to see what length of extension we need. So we're going to put back that marker pigtail and try to see where the bifurcation is, the iliac bifurcation. All right, so show us lower down, please. Yeah, that's fine. Okay, so we have reached the flow divider with the first marker of the pigtail. And now we'll look from below and see where the iliac bifurcation is. Okay, maybe a little LAO and a little caudal, 10-10. Yeah, I'm just trying to open out that, show lower down, open out the iliac bifurcation. All right, so you can see that it is a little ectatic and almost aneurysmal, you would say. We measured that as about 18. So we are going to take a 20 millimeter device and let us now count how many centimeters we have. Okay, 1, 2, 3, 4, 5, 6, 7, 8. 8 to the top of the screen. 9, 10, 11, 12. 12. So we'll need a 120 millimeter device. Yeah. So this device is 16 on top, where it will mate with the contra gate, and then it will be 20 at the bottom. AP view, or maybe you stay there. Now the other thing is we need to be able to see that iliac bifurcation. Yeah. So what we'll do is we'll freeze the image on the screen and then we won't move the table. Okay, so you take off the pigtail.
George, the plan is to do an angiogram right now.
Okay, here we go. We are what we'll show lower down, please. We are going to take a picture of the iliac bifurcation, freeze it in that position, and then we'll know that that's where the device has to end. Show a little higher up. So that we can see everything in one view. Table up. Okay. Yeah, so little higher up. All right. Okay. I think we've got the flow divider right on top and the iliac bifurcation at the bottom. All right. So we are. Can you put get a pen and mark on the screen?
George, do you think we can quickly break for a small talk here and come back to you?
Is the device ready? Yeah, that's fine. We just have to deploy this and balloon it and then we'll be done. You could come back. We can show you what we have done.
Right. So we will come back after 10 minutes and you show us what you have done.
Okay. Sure. Okay.
Okay. Thanks, Jim.
Yeah. You ready with the device? You'll have to, it will bleed a bit.
I think we will have a lecture by Dr. Samir Dani on assessment of peripheral vascular disease, indication for intervention in peripheral vascular disease. And we'll come back to you, Dr. Joseph, again once we finish this. Thank you.
Okay, so good afternoon, everyone. This is like after identifying patients with asymptomatic as well as symptomatic undiagnosed peripheral vascular disease. They have 30% risk when they are symptomatic of death within 5 years in many, as shown by many epidemiological studies, nearly 50% within 10 years. Many patients with peripheral vascular disease assume that their symptoms are part of growing old, so do not present to their physician. It can be easily detected in clinical practice, doesn't need much of equipment, just awareness about the presence of peripheral vascular disease needs to be there, and it needs to be increased amongst the patients as well. Peripheral vascular disease should be considered in any patient with exertional leg pain, patients more than 50 years old with diabetes, patients more than 50 years old who are currently smoking, all patients more than 70 years old, and recently ACCAHA has added a corollary to it. This criteria has been downscaled to 65 years old. Anyone more than 65 years old does merit a quick screening for peripheral vascular disease. It may also be present in patients with evidence of past TIAs or strokes, suspected carotid artery disease, non-controlled or uncontrolled hypertension, abnormal renal.
Yeah, okay, deflate. We are just dilating that neck again. Can you show the previous angio? Yeah, we finished everything and we did this angiogram, and it looked good, except there's a very slow, late type 1 leak from above. It is coming from just near that left renal artery. Now this may stop on its own, but I thought I'll just balloon it once more and maybe oppose that a little better. And we'll then accept whatever we got. And if it persists on CT, say after a month or so, then we may have to put a cuff and extend the graft a little above and maybe have a couple of stents in the renals to protect them. So that we'll see. Maybe this leak will stop. This is a very extremely slow leak. You don't see it for several frames.
Can you see that final picture one?
Late, you can see a little bit of sac filling from above.
Hello, George. Can you see the final picture of your patient?
George, we can't see you nor the pictures.
Yeah, yes. Yeah. Oh, I see. They can't see us, it seems, or the pictures.
Yeah, now we are able to see.
Now you are there.
Okay, we'll take the balloon out. You reach some force. Okay. Okay, so we did a balloon dilatation. We can take another angiogram. Let's get the pigtail. Quickly get the pigtail and put it on this. Yeah. Just help me. We need a breath hold, please. No, go back to that previous view so that we can see everything. Show the catheter. There's the catheter. Show the pigtail. It's on top. Come down. Okay. Now show the whole thing in one view. Table up maximum and Tweak, okay. All right, so we'll pull back the sheets. Okay. Are you ready then? Okay, breath hold please. Holding now.
That's okay.
I think it is reduced from the previous one.
Increased.
It is very, very trivial now.
Yeah, can you show that previous picture?
So I feel this might settle on its own. Yeah, go back to the previous angio. Before that, yeah. So this is the previous one where there was a fairly distinct filling of the sac, but again very late. You can see that towards the end of the angiogram. Now show the last one. No, go back to this. Yeah, this is our last picture. It's probably very trivial. I feel that this is going to seal off on its own.
Okay, that was an excellent demonstration. Congratulations once again, and we'll break from you as you decided to leave it alone. Thank you.